Okay, everybody. Well, thank you so much for joining us for today's lunch. Today's lunch is called Unlocking the Value of Cardiac PET Imaging, Considerations for Launching an Exemplary Program. We're really excited to bring this to you today. We're really grateful to Bracco for sponsoring this lunch. And I'd like to introduce today's speaker, Ms. Jory Ward. She's the Chief Operating Officer of Naples Heart Rhythm Specialists in Naples, Florida. And we're so grateful that you could be here to share your expertise with us. Jory, thank you so much.
Thank you, Joe, and thank you everyone for joining me here today. I appreciate you taking the time to learn a little bit, hopefully, about cardiac PET, and I'm going to do my best to pique your interest in it and hopefully give you some tips and tricks along the way that you can take back to your institution. Quickly, one disclosure I do have to give you. I have a financial relationship with Bracco. I do receive funding from the organization as it relates to the content of this program. But this relationship has been managed in accordance with MedAxiom's policies to ensure objectivity. So without any further ado, we'll go ahead and get started. My goal today is to give you some information and some guidance as far as how an investment in a cardiac PET program and in cardiac PET imaging can deliver exceptional returns for you, both from a clinical perspective as well as financially. I want to help you discover the power of partnership between administrators, which many of you probably are, your clinicians, your cardiologists, as well as your nuclear team and your nuclear technologists, and the overall organization to achieve that optimal success. And then lastly, hopefully, we can learn the blueprint and give you some of those tips and tricks for starting your program and developing that operational and clinical excellence. So I would be remiss as a nurse if I didn't state my disclaimer that, we're all here with the goal of making money, right? But it's always with the intent of keeping the patient at the forefront, doing the right things for the patient, getting the right imaging, getting the right study to drive those initiatives going forward. But in my other hat as an administrator now, we have to look at the bottom dollar. So I'm going to start this getting in a little bit with talking about how you can achieve your ROI, which, again, is the goal of any program. So you want to achieve that ROI as soon as possible and subsequently maximize your profits. My 10 years of experience have shown that, while cardiac PET formerly was only indicated for FDG with viability studies, there are broadening expansions for cardiac PET, increasing indications, improved payer adoption, as well as CMS and commercial coverage. So with all of these, who knows where cardiac PET is going to take us in the next 10 years. For 2025 alone, just a couple numbers to throw at you, CMS reimbursement for cardiac PET went up by 2.9% within the HOPS fee schedule. And for 2026, CMS is proposing another 2.4% update, as well as increasing its reimbursement for how it pays for diagnostic radiopharmaceuticals. So in the realm of a lot of cuts being made and a lot of decreasing coverage, the future truly does look good for cardiac PET. So how do you make it happen, right? You need to crawl before you walk, but definitely bite that bullet. Make it happen. If your program needs to start in a basement, for example, go ahead and do so. Put it where you have available space. If you have a freestanding facility as part of your program that can be outfitted for cardiac PET, you can go ahead and put it there. I will tell you, from start to finish in the development of our program, it took me less than 6 months and less than $1 million to go from a complete demolition of our freestanding facility to a build out, literally from dirt floors and exterior walls. I know this was a few years ago, but this is also in Naples, Florida, where things are definitely not cheap, right? You can also start with a refurbished machine if your budget only allows for that. cardiac PET does not have to be cost prohibitive. You can still achieve the same superior diagnostic yield, clinical accuracy with your quantification of myocardial blood flow, and better risk stratification to improve patient outcomes and reduce long-term costs to guide your appropriate downstream clinical measures for your patients. So just as an example, compared to cardiac SPECT, which we know for years has been the standard of care in non-invasive diagnostic imaging, PET does yield higher reimbursement rates. Per scan, you're looking at an overall reimbursement of, depending on your geographic region, roughly $1,200 to $1,500 per study, as opposed to cardiac SPECT, where you're looking to gain about $300 to $500 per study. Studies also only take start to finish less than 30 minutes with your cardiac PET, as opposed to easily over an hour for SPECT. Sometimes you have a 2-part study and you're having to do that over the course of a morning and an afternoon, or even potentially a 2-day period of time. So you can do many more and you have a much higher throughput with cardiac PET than you potentially do with some of these other conventional studies. I'm not saying that there's not a place for cardiac SPECT imaging, right, in your facility. There absolutely is, and we do, in fact, still maintain a SPECT camera ourselves. But what I'm saying is that you don't have to use it for increasing number of patients, and cardiac PET is being integrated for increasing diagnoses. And despite its higher initial investment, there are lower operational costs per scan when you invest and partake in a generator-based protocol with PET tracers. This will reduce your long-term costs when utilization is optimized, and I'll give you an example of that on the next slide here in a second. And lastly, you have asset longevity, duality of use. When you're starting out your program and you are trying to get that buy-in from your key players, you know, it's that crawl before you walk thing, right? Your equipment can start out and be shared use with perhaps oncology or neurology. Get that referral base, get your program up and building, and then you can grow and become an independent center from there. You can, like I said, you can absolutely crawl before you walk. These capital investments, while they do have an upfront cost, they have a longevity and a life estimate of easily 10 or more years when they're well maintained. And furthermore, cardiac PET is aligned with AI integration, making it a forward compatible investment. So as I said, I'm going to give you a little example here, some sample ROI calculations. Talking in ballpark numbers, but nonetheless, if you're starting out, let's say you do 5 scans a day, 5 days a week, Monday through Friday, you're running an 8 to 4:30 outpatient program. That gives you a total of about 1,250 scans a year. And like I said earlier, reimbursement can range anywhere from $1,200 to $1,500. So I threw $1,300 out there, somewhat on the conservative side of things, right? That gives you an annual revenue of $1.625 million. And let's take into consideration your operating costs, roughly maybe $500,000 for staffing, for your equipment, supplies, maintenance, perhaps vendor contracts, and all of those things in there. You're still looking at this point, 5 studies a day with a net revenue of $1.125 million a year. That basically covers your capital investment, your initial costs, within a 2 to 3 period of time. And from there, you've established your program, right? You are honed in on your scheduling, you've built that referral network, you have buy-in on cardiac PET, so you get to a point where you're able to do 18 scans a day. This is what we're doing at our facility. It is feasible. We still do it in an 8 to 4:30 day with 2 technicians, and we're doing, 30-minute studies. That gives us now a yield of 4,500 scans a year, keeping reimbursement at that $1,300 point for comparison. We now have an annual revenue of $5.85 million. With this, you subtract some additional operating costs, right? You have some additional staffing and some additional resources with supplies. Your net revenue is now at $5.25 million. So to me, I don't know, this seems crazy. It seems like a no-brainer, right? So my question to you is, what are you waiting for? The evidence is there supporting cardiac PET as a tool for any institution, outpatient, inpatient, hospital facility, whatever. So moving on, I am a big fan of idioms and analogies, and I know I threw the crawl before you walk and a couple others at you already, but I'm going to give you a few more now. No man is an island is one. It takes a village, and teamwork makes the dream work, right? So here in no particular order is your team. As an administrator, if you are, the onus is on you to really get this ball rolling. Collaboration and buy-in from multiple facets is essential, especially if you're part of a larger hospital system or a healthcare network. Partnering with your cardiologists who truly believe in cardiac PET and who are trained in cardiac PET, it seems like an obvious step one maybe, but it is essential in having that collaboration and having them really spearhead this program with you. If you don't have cardiac PET trained nuclear cardiologists, recruit them, quite honestly. They're out there and they're coming out of their training with expertise in this field. It's becoming more and more of a standard in your fellowship programs. Radiology support, especially if you're part of a larger institution, is also key for this. Oftentimes your radiologist kind of own the decision-making as it relates to imaging components in a larger healthcare system. So partnering with them and getting their buy-in really is imperative, right? And as I shared before, if you need to start with a shared use system when making this a more palatable option as it relates to presenting a plan and a pro forma to your key decision makers. Having that buy-in from radiology who really can work with you in tandem and support that could potentially be game-changing for your institution, depending on how you are set up. Another key component of this is your nuclear technologists. If you're part of an organization, you likely already have nuclear technologists as part of your program. And more than likely, they're already trained in cardiac PET, whether you're using the technology at your facility already or not. You want to meet with your technologists early and often as you begin this program and truly work with them and partner with them through the entire process, as they really are your boots on the ground as it relates to starting a program. You want to get their input and really trust their recommendations along the way with making some of these decisions. And quite honestly, just importantly, you want to know from them what to avoid. And who perhaps not to partner with, or where some of those limitations lie on a day-to-day basis. So I truly believe your nuclear technologists are key in developing a well-run, efficient, high quality, and ultimately clinically and economically successful program. The next group of people, I know this is usually part of a different topic in a different subset in a different meeting, but I cannot say enough about making sure that you have high quality, well-trained certified cardiology coders and billing specialists to engage and really to partner with in developing your program. The indications and the requirements for billing are ever changing when it comes to CMS as well as the commercial payers. And having someone who is really passionate about this and who really is staying up to date in this can truly make or break your program. as it comes to the changes. They're happening several times a year with not only CMS, but also with the commercial payers. And if your billing team is not up to date with that, it can become really costly for your program, or at least, cause significant delays in reimbursement that you definitely want to avoid. Also, a very relevant and crucial part of your team, right, is your referral network and using marketing to obtain those referrals, whether that's internally within your organization or if you are more community-based and you're looking to referring cardiologists, primary care physicians, really targeting that referring network, getting the word out there early on cardiac PET. It's a highly specialized diagnostic tool, right, that not everyone has in their back pocket, and perhaps, some of your competitors in your geographic area may not be utilizing cardiac PET either. So you can really capitalize on that referral network, and I would, in tandem with that, say, utilize that as part of your marketing too. It's important to upfront get that word out there, like I said. So make the initial investment in a good marketing campaign. If you have to get someone who can really pound the pavement, go door to door and talking to your referrals, it's worth it. You don't want to sacrifice on that, and you want to keep cardiac PET at the forefront of these referrings' mind, right? So ongoing marketing and ongoing communications, both with your referrings as well as out in the community, is key to success in developing your program. And not only are your internal collaborations imperative, but strong ties with your vendors and establishing solid contracts is also key to the startup of your program. If you're part of a facility that already does imaging, you likely already have a lot of these things in place. And for those that you do, lean on them and also use them to network and to establish the new connections that you need along the way. There's definitely no reason to reinvent the wheel if you don't have to. The vendors can and want to see you succeed, as that ultimately leads to success for them as well, right? So find those relationships, find those ones that sincerely want to help you. Like I said, lean on those and partner with them as well. So now that you have all this stuff, the buy-in from your key players, the data to show you that this can be successful financially, as well as determining your capital equipment, staffing needs, and so on. How do you put all this together to make it work, right? How can you get this multi-million-dollar return that I'm telling you is out there? I'm going to try and do this in the little time I have left, but I'm going to start by giving you my don'ts and my do's as it relates to developing a cardiac PET program. I'm not going to do it the other way around. It's not my do's and my don'ts. It's my don'ts and my do's, because I want you to take home with this what to do when it comes to starting your program, not what not to do, right? So first and foremost, we talked about it a little bit, but don't understaff and don't hire poorly trained staff. It goes without saying, right? You want to have sufficient staff, but you also want to be able to progress your program forward. So hiring those personnel that have the knowledge and that are coming out of programs, or recruiting them from programs where they have a background in cardiac PET, can really serve you well in the long run. That may also mean, as your program grows, hiring a second technologist, or even hiring a medical assistant to help with prep and turnover of your rooms, or even both, depending on where you're at and how quickly you do grow. You don't want to sacrifice quality and staffing for what may save you a few bucks in the long run when you're looking to really expand your program and really capitalize and gain that maximum return on your investment. So another don't not communicate, right? That's my double negative here. But don't not communicate, not only with your internal team and with your key players and your key decision makers, but also with that referral network that you have. Your internal physicians from out the community. You can become that destination center of excellence, and you can draw from a much larger pool potentially than just your own healthcare system if you're part of a larger one. Most people don't have cardiac PET, so there is a real opportunity here for you to capitalize on. We maintain, as part of our program, a 24-hour turnaround time with all of our results. And that means that results are sent, whether it's via, direct EMR, or we're faxing it, or whatever we need to do. With all of our referrals, we're getting those results back in 24 hours. And still to this day, we do actually call our referring our cardiologists, our primary care physicians, with any abnormal results. And in fact, when we first started this, in order to develop our program, we were actually hand delivering results to the referrings. Seems a little bit labor intensive, but when we were only starting out and we were doing 5 studies a day, we were able to utilize our team and capitalize on that. What we did is we really tied that into our marketing platform, and it got us in front of the referrings. So we were able to really keep cardiac PET at the forefront of their brains when they were making those decisions for ordering cardiac testing and sending those referrals. That really turned into a win-win for us. So, like I said, we do still maintain that close collaboration with our referrings and communicate extensively with them to make sure that we're providing as high of quality care as we truly can. Again, don't ignore your pre-authorization and your billing requirements. I know I said this already, but I will preach it until the cows come home. These players, I call our certified cardiology coder. She is my guru. I threaten anyone with physical harm if they ever will try and poach her. I promise you, she is worth her weight in gold. She's got an incredible team that works with her. But again, not having that, it truly can be costly to your organization. Having that knowledge up front and staying on top of that minimizes our needs to resubmit because of improper coding, improper medical documentation, not having the correct documentation for medical necessity. If we can stay on top of it and make sure that we're meeting the requirements up to date, our turnaround time for our payments, is exponentially increased that way. And last, don't be afraid to collaborate, commit, invest, succeed. Whatever it is that has caused you not to jump in on this to date, if you can identify those hurdles, work with your team to figure out what those are and how to overcome them, you can ultimately get to the point where you start this program, right? And you will ultimately see that ROI sooner than later. So the sooner you get started, the sooner you're profitable. Kind of goes without saying, right? And I promise you, if I can do this, y'all can too. So moving on to my do's. Do perform a feasibility study. When you get out of here, if this is something that you're truly thinking of for your program, which I hope you are, and I hope you do, run some reports. Get the numbers as they relate to your facility. And from there, you can secure financial funding, backup, loans if you have to. Set a meeting with your contractors, with your architects to really get a timeline in place, really know what you're starting with and what this is going to look like for your facility. You want to have those realistic expectations in place, and I guess, like anything you build, or if you're building a home, it's your cost plus 20. Budget that in there, but like I said before, you can truly do this for a very reasonable amount of money, and you can do it if you have a team together in a very quick turnaround time so that you can get started with your imaging and taking care of your patients in this way. And do build your strong interdisciplinary team. I talked about your cardiac PET trained cardiologists, as well as your nuclear technologists. If you don't have those people, go out and find them. Go out and recruit them. That too, becomes a part of your overall expense. But putting it into that ROI like we did earlier, those costs are quickly offset. And do vet out your equipment, begin your vendor discussions early on. You'll ultimately have to determine what works best for your program, what equipment is going to be the best option for you, whether it's shared use, whether you start out just biting the bullet and making that capital investment, but use those vendor relationships along the way. My years of experience have shown me that the collaborative relationships with your vendors can really serve you well. You want to engage with the ones that want to help you succeed, and they're out there. Of course, they want to be successful, but their ultimate goal is to see you succeed, and ultimately they'll reestablish and reaffirm their relationships with you along the way and achieve subsequent success themselves. So the vendors have oftentimes paved this road for you. Use their relationships and use their knowledge. You don't have to do it alone, and use their guidance to see what's going to be the best options for you. And let them help you run that pro forma as well if you can. And then from there, you can focus on building your schedule efficiently with solid protocol development and a generator-based model. I and our program are a huge proponent in supporting generator-based models because of their efficiency as well as their profitability. There is, of course, a niche for other protocols, and those should absolutely be used, and they can be used selectively in specific subsets of patients. But a generator-based platform will truly give you the maximum return on your investment. And lastly, plan for your future if you can. 10 years goes by really quickly, trust me. I look back and it seems like it was yesterday. But if you can prepare for your anticipated growth and the center of excellence that you want your program to become, do so up front, right? So when we built our facility, we actually took the time and we put 2 rooms side by side with the ultimate goal of having 2 PET machines and having the volume to support that. But doing so allowed us to take those upfront construction costs and put them into the initial rather than going back, reconstructing, ripping out walls to add more lead and so on. So figure out where you want to see your program in 10 years. And as long as your budget allows for it and you've got the ability to do so, plan ahead for that. It will definitely save you in the long run. And finally, I would be remiss if in today's day and age, I didn't use ChatGPT somewhere in this presentation. So I asked ChatGPT to give me a 2-sentence summary on why one should implement a cardiac PET program in their institution. So here's what ChatGPT said, and I think they nailed it. So I appreciate you all very much for being here, taking the time. If you have any questions, they're not allowed. I'm kidding. But no, I would love to answer any questions that you do have if I can, and please.
Thanks, that was great. I just had a
Thanks.
question regarding the, just had a quick question regarding the economics that you were talking about.
Sure.
Can you say a little bit more about generator versus cyclotron-based economics, like how that works?
So cyclone-based PET is, I'm not part of a large healthcare system, right? So that has to be my disclaimer here, is that was not something that was actually on the table for us. So I don't know if you guys have any experience with it in the back. I don't have experience with cyclone train based, so I feel like it would be unfair and I'd be remiss to try and comment on something with that. So I look at either, pharmaceutical based or generator based, and for me it's a no-brainer, right, as it relates to the profitability.
And so it's rubidium, I assume?
Yes,
right?
correct,
Okay.
correct.
And then how long were you using, or did you ever use an oncology sharing program, or did you just buy your machines right off the bat?
We did not. So what we did, starting out, we actually did buy our very first machine was a refurbished machine from a third-party vendor, right? So we were able to save upfront costs with that, and that doesn't go into the less than $1 million build-out, right? So buying your equipment is on top of that. We did buy a refurbished machine, third-party. It had a service contract that came with it, right? Within that 2-year period of time, we realized that we were going to be okay, and that was our crawl before we walk. This was a little bit unprecedented where we come from. And in Naples, Florida, no one was really doing cardiac PET. And really 10 years ago, not a lot of people were doing PET anywhere. So we wanted to make sure that we had both feet on the ground. We did buy a refurbished machine, which I 100% think was the right thing to do for us. And I think it can be for a lot of people. But we have since then upgraded our equipment, right? purchased a new machine, a new equipment. Pros and cons to both. As the other machine did see some wear and tear, you know, we were having to spend increasing costs on maintenance and that sort of thing. So now with a new machine, you know, we have our warranty, which will ultimately lead into a service contract. But these machines, well maintained, like I said, have a very good lifespan on them for sure. So, of course.
So just to add on, Jamie Warren, part of the MedAxiom team. So if you're talking about cyclotron, you talk about ammonia, or you talk about F-18 products, ammonia. So with that, what we would suggest is that you actually work with the vendor that is providing ammonia to then build out your pro forma on what your pricing would be, and then obviously for billing and reimbursement. From a shared service perspective, MedAxiom actually has a paper that is published that you're able to download that walks through the benefits and then kind of the operational pieces of putting together a shared service. You can grab me after this talk if you have any additional questions. I will say that it is a great way to start into PET. So if you are not sure if you would have enough volume to do a full I manage 100% the cardiac camera, it is a great way to get into this and then also be able to develop your relationships with radiology.
Thanks, Jamie.
Can you tell us where flurpiridaz is going to be in the modern PET program, where you see that?
So without a crystal ball, I definitely do think that there's a niche for flurpiridaz. And I know my nuclear cardiologists see some benefit to it as well. I think in certain patient populations, there's always going to be, nothing's 100%, right? So there's always going to be clinical indications or certain scenarios where flurpiridaz has its place. But for us, as a program, in order, like I said, to achieve profit and to really maximize our resources in gaining that throughput and in maximizing the number of patients and the number of studies that we can do, while, you know, at the same time, we're already achieving what, like a 98.9% specificity and sensitivity. There's no reason to sacrifice our volume and our revenue for flurpiridaz or any other agent really 100% of the time. So that's our take on it, and that's our stance on it, which is why we do prefer the generator-based model. We're still able to get, you know, the same high acuity and sensitivity of results. So I know it's not a direct answer to your question, but I feel like it's a little more niche.
We've got time for one more question.
What are you guys seeing on your denials side? Have you guys transitioned like literally all of your spec to?
Absolutely not. No. We still, like I said, we still have a SPECT camera at our institution. We still do use it. There's clearly a place still for cardiac SPECT. We 100% believe that. We do it ourselves. As far as denials, the main thing is really meeting medical necessity, right? Having that documentation in place, and that starts with your clinicians. So we will actually, and if we need to from a clinical perspective, not that we can, but we will talk to our referrings. We will upgrade or downgrade a study, for lack of a better way to put it. You know, not that one is a downgrade to the other, but we will change a study if it's indicated. So whether it's a patient, whether it's going from SPEC to PET or vice versa, sometimes you can't get coverage for a cardiac PET, right? Especially with some of these commercial payers. In that instance, by all means, we'll give them a SPECT. But if we can fight for what we truly believe will be a better diagnostic tool for that patient, we will take the time to do that. That's where my guru comes into play, for sure. But we have macros in place. We make sure, and we do ongoing training with our clinical team to ensure that they've got the correct documentation. They're documenting that need for medical necessity so that when we submit for pre-authorization with the commercial payers, we're not having to go back, get those denials, and then having to reinvent the wheel and fight that. So that's, like I said, that's something I'll preach till the cows come home. That component of it, I truly think can make or break a program. It really can. So.
Great. Thank you, everyone, for attending the session today. Yep. Big thank you to Jory Ward for sharing her insights, and to our industry partner, Bracco, for sponsoring the session and bringing her to everyone. And hope you all have a great rest of your conference. We will be following up with the presentation from today via email with you.